presenting on Chapter 2, Behavior Change and Exercise. In this presentation, we will mainly be talking about how health-related behaviors both have a positive and a negative impact on our personal health. And we will also talk about the different models of behavior change and how each model relates back to exercise itself. I'm going to introduce this just so everyone knows how America as a whole participates in exercise. According to healthypeople.gov, more than 80% of adults do not meet the guidelines for both aerobic and muscle strength activities. Similarly, more than 80% of the adolescents do not do enough aerobic physical activity to meet the guidelines for youth. Data conducted by the National Health and Nutrition Examination Survey between the years 1976 to 1980 and 2003 to 2006 clearly demonstrate that obesity levels have risen. The prevalence for obesity for children ages 2 to 5 years old increased from 5% to 12.4%. Kids ages 6 to 11 showed an obesity prevalence increase from 6.5% to 17%. Young people ages 12 to 19 showed an obesity prevalence increase from 5% to 17.6%. Physical activity is very important when it comes to health behavior of an individual, and there are some people who take it upon themselves to engage in physical activity, understanding that their inactive lifestyle isn't helping them to be successful. But for the rest of the United States, who don't meet the physical activity guidelines must try to meet them considering the obesity levels in the United States. Some of the objectives we will look at over this period for the presentation is to define health-related behavior, talk about specific behavioral models that are used to measure and predict behavioral choices, how perception and attitude towards daily physical activity and exercise is impacted by our behavioral choices, and discuss how we as a population can increase and continue daily physical activity and exercise. Now we will talk about health-related behavior. According to study.com, the definition refers to a person's belief and actions regarding their health and well-being. As a good example of this, some people's health behaviors jive well with promoting and maintaining healthy lifestyles. People on their best health behavior do not smoke or use any other tobacco products, do not drink in excess. This means no more than 2 drinks per day for a man under age 65 and 1 drink per day for a woman of any age or a man over age 65. They also exercise regularly. As a case in point, you can perform 2.5 hours of brisk walking every week to help improve your physical fitness. And furthermore, such people eat well. This doesn't solely imply you should just eat more fruits and vegetables, which is true, but it also means you should simultaneously cut back on salty foods, greasy meals, and too many things with simple sugars like cola or sweets. Now we are going to take a look at theoretical belief models that are most frequently used to measure and interpret behavior and physical activities. A lot of these models are where we get our information for specific health behaviors that our population may be currently involved in. We can use this information to help increase our physical activity and exercise. The models that we will be looking at today are James Prochaska's trans-theoretical model, Stages of Change, Albert Bandura's social cognitive theory, and the health belief model. The first model we will talk about is the trans-theoretical model, created by Prochaska and DeClement in the late 1970s. The trans-theoretical model focuses on the decision-making of the individual and is a model of intentional change. The trans-theoretical model operates on the assumption that people do not change behaviors quickly and decisively. Rather, change in behavior, especially habitual behavior, occurs continuously through a cyclical process. The trans-theoretical model is not a theory, but a model. Different behavioral theories and constructs can be applied to various stages on the model where they may be most effective. Now we will talk about the 6 stages of the trans-theoretical model. The 6 stages are pre-contemplation, contemplation, preparation, action, maintenance, and termination. Pre-contemplation is the first one. In this stage, people do not intend to take action in the foreseeable future. People are often unaware that their behavior is problematic or produces negative consequences. People in this stage often underestimate the pros of changing behavior and place too much emphasis on the cons of changing behavior. Second one is contemplation. In this stage, people are intending to start the healthy behavior in the foreseeable future. People recognize that their behavior may be problematic, and a more thoughtful and practical consideration of the pros and cons of changing the behavior that takes place with equal emphasis placed on both. Even with this recognition, people may still feel uncertain or hesitant toward changing their behavior. The third is preparation. In this stage, people are ready to take action within the next 30 days. People start to take small steps toward the behavior change, and they believe changing their behavior can lead to a healthier life. Fourth is action. In this stage, people have recently changed their behavior and intend to keep moving forward with that behavior change. People may exhibit this by modifying their behavior or acquiring new healthy behaviors. Fifth is maintenance. In this stage, people have sustained that their behavior change for a while and intend to maintain the behavior change going forward. People in this stage work to prevent relapse in earlier stages. And the final stage is termination. In this stage, people have no desire to return to their unhealthy behaviors and are sure they will not relapse. Since this is rarely reached and people tend to stay in the maintenance stages, this stage is often considered in health promotion programs. So reasons why physical activity and exercise is low. The number one reason for this, according to research, is time. We can often relate to that. Time is a very difficult thing to manage. It's very difficult to set aside more time in our lives, so that becomes a really big problem for being able to stick to a regular exercise routine. Also, attitude is high on the list. This could be attitude towards perceived risk or yourself, the way you feel about yourself or the way you feel about what could possibly happen to your health in the long run if you don't do anything about it. One of the bigger reasons would be self-efficacy. This is just having the confidence in your ability to be devoted to exercise regardless of reasons not to exercise. Another reason would be social determinants such as socioeconomic status, the level of care available in the neighborhood, or policy by lawmakers. There's a number of things that could affect whether or not a person gets the recommended physical daily activity. A lot of times this comes from people with low incomes. The reason being is that they don't have the resources available. Decisional balance will be the last one we would talk about. This is more about weighing out the good and the bad about exercise in relation to your health status level. If you feel like you're unhealthy and you want to be healthier, then you will have to weigh out what it's going to take for you to get there as opposed to not doing anything at all. The trans-theoretical model applied to exercise for an inactive person. So for pre-contemplation, we have an individual who is inactive and knows that it is unhealthy. As we move into the contemplation stage, the individual starts to evaluate his or her lack of exercise. This is where the individual will weigh out the pros and cons of adopting a new activity. If the individual decides to adapt exercise as their new activity, then they will move on to the preparation stage and will start to develop and come up with different opportunities for exercise. Once the individual chooses their own option for exercise, which in this case we'll say it's 3 days per week, then they will start to take action. So after several weeks, this individual can manage exercising for 3 days per week. If the individual is successful with sticking with this program for over 6 months, then the individual can then move on to the termination stage. But we must note that the termination stage is very hard to get to. Not everyone can get to this stage because they tend to fall into a relapse for many different reasons. Most reasons being the ones listed in the previous slides. The next model we will talk about very briefly is Albert Bandura's social cognitive theory. In this particular theory, Bandura looks at mediating processes that could occur between a stimulus and a response, more or less what is going to create a specific behavior. He also was concerned with the behavior is learned from environmental through the process of observational learning. We will quickly look at the four mediational processes that occur between a stimulus and a response. The four mediational processes are attention, retention, reproduction, and motivation. Attention is the extent to which we are exposed or notice the behavior. For a behavior to be imitated, it has to grab our attention. We observe many behaviors on a daily basis, and many of these are not noteworthy. Attention is therefore extremely important in whether a behavior influences others imitating it. Second is retention, which is how well the behavior is remembered. The behavior may be noticed but is not always remembered, which obviously prevents imitation. It is important, therefore, that a memory of the behavior is formed to be performed later by the observer. Much of the social learning is not immediate, so this process is especially vital in those cases. Even if the behavior is reproduced shortly after seeing it, there needs to be a memory to refer to. 3. Reproduction. There is an ability to perform the behavior that the model has just demonstrated. We see much behavior on a daily basis that we would like to be able to imitate, but this is not always possible. We are limited by our physical ability, and for that reason, even if we wish to reproduce the behavior, we cannot. 4. Motivation. The will to perform the behavior. The rewards and punishment that follow a behavior will be considered by the observer. If the perceived rewards outweigh the perceived costs, then the behavior will be more likely to be imitated by the observer. If the reinforcement is not seen to be important enough to the observer, then they will not imitate the behavior. And finally, we have the health belief model. It was developed in the early 1950s by social scientists at the U.S. Public Health Service in order to understand the failure of people to adopt disease prevention strategies or screening tests for the early detection of disease. And over the years, this has become one of the most popular used theories for prevention and intervention programs worldwide. There are three main categories that divide this model to better understand its components. One is individual conception, which is the understanding and views that the person has about his or her behaviors and the potential outcomes their behaviors can result in. Second is modifying factors, how threatened an individual feels about the evaluation and usage of outside influences. And third is the likelihood of action, which helps individuals determine whether or not it is worth engaging in a healthy behavior. Are the limitations or benefits stronger? There are 6 constructs of the health belief model. The first 4 constructs were developed as the original tenets of the health belief model. The last 2 were added as research. First is perceived susceptibility. This refers to a person's subjective perception of the risk of acquiring an illness or disease. There is a wide variation in a person's feelings or personal vulnerability to an illness or disease. Second is perceived severity. This refers to a person's feeling on the seriousness of contracting an illness or disease. There's a wide variation in a person's feelings of severity, and often a person considers the medical consequences and social consequences when evaluating the severity. Third is perceived benefits. This refers to a person's perception on the effectiveness of various actions available to reduce the threat of illness or disease. The course of action a person takes in preventing illness or disease relies on consideration and evaluation of both perceived susceptibility and perceived benefit, such that the person would accept the recommended health action if it was perceived as beneficial. Fourth is perceived barriers. This refers to a person's feelings on the obstacles to performing a recommended health action. There is a wide variety in a person's feelings of barriers or impediments, which lead to a cost-benefit analysis. The person weighs the effectiveness of the actions against the perceptions that it may be expensive or dangerous, unpleasant, time-consuming, or inconvenient. Fifth is cue to action. This is the stimulus needed to trigger the decision-making process to accept recommended health action. These cues can be internal or external. And last is self-efficacy. This refers to the level of a person's confidence in his or her ability to successfully perform a behavior. This construct was added to the model most recently in the mid-1980s. Self-efficacy is a construct in many behavioral theories as it directly relates to whether a person performs the desired behavior. Here are several limitations of the health belief model, which limits its utility in public health. Limitations of the model include the following. It does not account for a person's attitudes, beliefs, or other individual determinants that dictate a person's acceptance of a health behavior. It does not take into account behaviors that are habitual and thus may inform the decision-making process to accept a recommended action. It does not take into account behaviors that are performed for non-health related reasons such as social acceptability. It does not account for environmental or economic factors that may prohibit or promote the recommended action. It assumes that everyone has access to equal amounts of information on the illness or disease, and it assumes that cues to action are widely prevalent in encouraging people to act, and that health actions are the main goal in the decision-making process. In conclusion, through the duration of this presentation, we have discussed the meaning of health-related behavior change, theoretical models used to measure and predict behavior, the main reasons why exercise adherence is difficult to initiate and maintain, and the current strategies proposed ideas to increase exercise and physical activity. We are either healthcare professionals or students moving in that direction, and it's very important to understand our responsibility in helping people develop specific strategies to become successful and maintain a healthy state of living. With that being said, we need to focus on helping them with a plan that works for their lifestyle. Something that can fit into their lifestyle, even if it's very small change. Any change is better than nothing. So I think setting up a plan with goals is one of the most important aspects in any of the strategies as far as being able to move forward from that point in the direction of improving health and well-being.